Hello, my name is Aamir Saeed, and I'll be giving a talk on mood disorders, psychopharmacology of mood disorders, anxiety, and somatoform and fictitious disorders. So, these are some of our objectives: to cover the symptoms, diagnosis, and management of depressive disorders and bipolar disorder, to cover the class of drugs for mood disorders, such as SSRIs and lithium, to cover the symptoms and management of generalized anxiety disorder, and finally to cover somatoform and fictitious disorders. So before we begin, I think a really good resource is this book, the Psychiatry Clinical Handbook. It was published in 2016 and you can find it in the library, but I think it really presents all the material in a concise form, and it's really easy to revise from. And it's also got questions at the end of the book, which help you to consolidate your knowledge. And it's got a really nice and colourful design too. So it's something that I'll recommend, as well as your PRN book. So we'll begin with depressive disorder. So it's an affective mood disorder. So it's important to understand the terms affect and mood. So your mood is your sustained internal emotional state, and your affect is your external transient emotional state. So it's kind of like the weather, and the seasons. So you can be in summer, so most of the time the weather will be good, but in between sometimes the weather might be raining. So the season would be the mood, that's your sustained emotional state, whereas your affect could be the couple of days of rain within that summer season. So it's transient emotional external state. So with a real example, so mood, you could have a very low mood, but there could be days where, for instance, it's someone's birthday where your mood could be elevated, but your background mood is very low. So that's mood and affect. So it's an affective mood disorder which is characterized by three core symptoms. These are low mood, low energy, and anhedonia. So anhedonia is not gaining pleasure from things that you previously gained pleasure from. So, if you like swimming before, or if you like going to the gym, and you no longer like those activities anymore, then that can be described as anhedonia. So it's important in terms of diagnosis of depression that you have at least two of these core symptoms, and also to make a diagnosis of depressive disorder or depression, the symptoms have to be present for at least 2 weeks. In some cases, you can have the core symptoms and patients may have other symptoms as well, and these can be split up into three categories, which can be the biological, cognitive, and emotional or psychotic symptoms. So in terms of cognitive symptoms, patients may have a lack of concentration. So, they might not be able to finish a book or do a crossword or a puzzle. They may experience excessive guilt or feeling of worthlessness, and they may have ideas of ending their own life. In terms of the biological symptoms, patients may experience a diurnal variation in mood, which means their mood can fluctuate depending on the time of day. So in patients with depression, their mood usually is the lowest in the morning, and they can wake up early in the morning as well, maybe a couple of hours before they usually wake up. There's also a loss of libido, and there can be weight loss and loss of appetite in terms of the biological symptoms. For the psychotic symptoms, you can have hallucinations, which is defined as a perception in the absence of an external stimulus. So you can have auditory hallucinations, visual hallucinations. You can also have delusions as well in very severe form of depression. So delusion is a fixed, firm belief which is unshakable and which it does not go with the background of the patient. So in depression, patients usually have delusions of guilt, poverty, nihilistic delusions as well. So these are type of delusions which the patients feel that they're dead, that sometimes a part of their body is decaying or rotting away. So in those cases, you can have those psychotic symptoms. So depression can be split up into different severity categories. So these are mild depression, moderate depression, and severe depression. So for mild depression, you can have two of the core symptoms, and you have two other symptoms from the biological, cognitive, or psychotic category. For moderate depression, you have two core symptoms, or you have 3 to 4 other symptoms. And for severe depression, you have all of the core symptoms, and you have 4 or more of the other symptoms from the biological, cognitive, and psychotic categories. So in terms of management, it's really important to assess risk of suicide each time a patient comes to you. So there are ways to assess risk of suicide, and you can ask questions to the patient about how, what their thoughts are about suicide. And for example, you can say, what are your thoughts on the future? Have you had dark thoughts of ending your own life or harming yourself? So these are some ways, or some sensitive ways, to actually ask and assess risk of suicide. So if a patient has mild to moderate depression, they can start them on low intensity psychosocial interventions. So these can include individual guided self-help. So that means you provide patient with written material that they can go through themselves, and that written material is about educating them on depression and challenging negative thoughts. Similarly, you can use computerized cognitive behavioral therapy. So that's a computer program or computer sessions that the patient can use by themselves, and again, it helps them, to get taught about depression, and helps them to challenge negative thoughts that they may have. It's important to know that it's not, all one size fits all. So you have to tailor your management depending on the comorbidities of the patient, the past medical history of the patient as well. So usually with mild to moderate depression, you won't need to start medication, but sometimes you might start an antidepressant, especially if they've had depression before and it was a very severe form of depression. So the management it's not very rigid. It really depends on the patient in front of you. But as a guide, usually you start with low intensity psychosocial interventions, and you won't usually start with antidepressants. However, if the patient has moderate to severe depression, you can usually use high intensity psychological interventions. These include individual CBT programs, and starting antidepressants such as SSRIs. Now, in patients with comorbidities, you can start sertraline, as it has a low risk of drug interactions and other SSRIs. Well, again, the use of which antidepressants that you use, it really depends upon the patient and what their comorbidities are. But it's important to know that SSRIs need to be continued for 6 months after symptoms resolve. So moving on to bipolar disorder, this is a mood disorder which is characterized by periods of depressive and then elated moods and increased activity. So either the depressive mood or the manic episode can occur first. It's either or. But patients who have had only manic episodes will eventually develop depression. So a manic episode is where symptoms last at least 1 week, and they can include elevated mood, extreme irritability, grandiose delusions. So these are delusions where people think they're kings or they're gods or they're the best thing in the world. Nothing can stop them. Pressure of speech, they are very, very talkative. It's very hard to actually to try and interrupt them and ask them questions. They have flight of ideas, so they can move from one idea to the next very swiftly. They have increased libido and disinhibition, and they can have decreased sleep, so they may only sleep maybe 1 to 2 hours a day, and they're very energetic. But what's important to know is that mania can lead to impairment in social or occupational functioning and may necessitate hospitalization. So these patients, when they have a manic episode, they may spend a lot of money on different things that can leave them vulnerable, and they can become so energetic that it might actually harm them from a physical standpoint. So that's why it's important that when you recognise a patient who might be experiencing a manic episode, it's really important to try and refer them to secondary care and psychiatry. So hypomania is where you have the symptoms of mania, but to a lesser extent, and they last for at least 4 days, and they're not severe enough to cause impairment in social or occupational functioning, and there is, very important to know, an absence of psychotic features, so they won't have the grandiose delusions that you see in manic episodes. So if symptoms suggest hypomania, then NICE recommend routine referral to the community mental health team. So if the person is experiencing a manic episode, or if they are a danger to themselves or other people, then it's important to refer them for urgent mental health assessment. So I've tried to organise the management of manic episodes and bipolar disorder in this table. So say, for instance, a patient comes to you at the GP, you recognise that they may be experiencing a manic episode. It's important to refer them to secondary care as soon as possible. So in secondary care, the first line treatments that they may use are haloperidol, olanzapine, quetiapine, or risperidone. So if a first line antipsychotic is not working, then they may use another antipsychotic from that list as a second line treatment. For third line treatment, if no antipsychotic is effective, then you can try lithium or sodium valproate. It's very important that you be cautious when you're using or prescribing sodium valproate, especially in women of childbearing age, because it can cause neural tube defects. So if they've got mania, if they've got a manic episode, then first line treatment is antipsychotics. If an antipsychotic doesn't work, then try another one. And third line is, if antipsychotics don't work, use lithium or sodium valproate. So if a patient is experiencing a depressive episode, you can either use quetiapine alone, olanzapine alone, lamotrigine alone, or fluoxetine combined with olanzapine. It's important to know that antidepressants alone are usually avoided because they can induce a manic episode. So for depressive episode, you can use quetiapine, you can use antipsychotics, anti-epileptics, or you can use SSRI in combination with an antipsychotic. So 4 weeks after the manic episode, the patient should be placed on medication to prevent relapses. So in patients who've experienced a manic episode, you can use lithium. But if lithium isn't effective initially, then you can use sodium valproate. But again, you've got to be very cautious in childbearing, in women of childbearing age, because it can cause neural tube defects. If lithium is poorly tolerated, then you can either use valproate on its own, or you can use olanzapine on its own. If patients have a depressive episode, then you can use high-intensity psychological intervention, such as individual cognitive behavioral therapy, and sometimes you can use mood stabilizers, such as lamotrigine. So mood stabilizers is just the term that we use to medication that can prevent relapses of bipolar disorder. So I'll move on to the pharmacology of various drugs that are used in the treatment of depression, depressive disorders and bipolar disorder. So SSRIs were, I think, introduced in the 1980s, and they really revolutionized the treatment of depressive disorders, and now the first line medication for depressive disorders. So the mechanism of action includes the inhibition of the reuptake of serotonin from the synaptic cleft into the presynaptic neurons. So with depressive disorders, there's the monoamine hypothesis that patients who have a low level of serotonin, noradrenaline in the synaptic cleft may be more likely to develop depressive disorder. So that's why these medications block the reuptake of these important neurotransmitters, and that can improve and treat depressive disorders. So examples of drugs in this class are citalopram, fluoxetine, and sertraline. And some of the main side effects include gastrointestinal disturbances such as nausea, bloating, and flatulence. People can experience insomnia and loss of libido. So I've added in a couple of do's and don'ts. So do prescribe sertraline post-MI, because there's evidence to suggest that sertraline is much safer for myocardial infarction patients than other antidepressants. And do review patients early on after starting an SSRI. And the reason for that is because, especially for younger patients, there's an increased risk of suicides when they start SSRI. So it's important to try and monitor these patients and assess the risk of suicide early on. So don't co-prescribe SSRIs and anticoagulants such as heparin and warfarin, because SSRIs are associated with GI bleeds. I apologise, I've made a bit of an error there, but I'll correct it on the PowerPoint. It should say anticoagulants such as heparin and warfarin. The reason you can't co-prescribe SSRI such as with warfarin and heparin is because SSRIs are known to be associated or increase the risk of GI bleeds. And also, it's very important not to stop SSRIs suddenly. They should be reduced slowly over a 4-week period. And you shouldn't prescribe citalopram or escitalopram in patients with congenital long QT syndrome, as these drugs can prolong the QT interval. So I'll move on to the pharmacology of lithium. So lithium is used to prevent relapses in patients with bipolar disorder. So it has a very narrow window of therapeutic windows. So normal therapeutic levels are between 0.4 and 1 millimole per litre, and toxic levels are those which are higher than 1.5 millimole per litre. Side effects include GI disturbances, fine tremor, polydipsia, which is increased thirst, increased weight, and fluid retention or edema. If a patient is experiencing lithium toxicity, then symptoms can include hoarse tremor, ataxia, hyperreflexia, convulsions, and coma. And lithium is contraindicated in severe renal failure, pregnancy, and breastfeeding, and untreated hypothyroidism. So again, I've added in some do's and don'ts for lithium. So do check use and ease, the EGFR, TFTs, and pregnancy status before starting treatment. Do monitor lithium levels 12 hours following the first dose, then weekly after the levels have been stable for 4 weeks, and then once they're stable, then check every 3 months. You should check use and ease every 6 months and TFTs every 12 months. And it's important to keep adequate fluid intake and prevent dehydration, because when you become dehydrated, the levels of lithium in your plasma and blood can alter, and that can lead to toxicity. So when you're counselling patients, it's important to mention that they should have adequate fluid intake. So especially if they're very athletic or like sports, then it's important to try and counsel them on that. So don't prescribe in women of childbearing age because lithium is teratogenic. Please don't prescribe in severe renal failure or untreated hypothyroidism, and don't withdraw lithium abruptly because it can lead to relapses. So now I'll move on to generalized anxiety disorder. So generalized anxiety disorder is a syndrome of ongoing, uncontrollable, widespread worry about many events or thoughts that the patient recognizes as excessive and inappropriate. And it's important to know that these symptoms need to be present for 6 months or more. Symptoms can include autonomic hyperactivity, such as sweating or increased heart rate, muscle aches, restlessness, sleep disturbance, and being startled very easily. So, in terms of the management of anxiety disorders, it's important to know that there's a stepwise treatment to approach. So I've taken this diagram from the book that I showed you earlier on, and it kind of really nicely summarises sort of the treatment plan for a patient. So if a patient comes into their general practice, it's important to identify and assess risk. It's important to assess risk factors that may make their anxiety worse. And it's important to try and actively monitor that patient and to provide them with some education about what generalized anxiety disorder is. So if patients are still experiencing symptoms, it's important to then move on to step 2. So step 2 is using low intensity psychological interventions. These can include individual non-facilitated self-help, so providing the patient with written material about GAD, and that should provide some. That can be a form of low intensity psychological intervention. Again, individual guided self-help and psychoeducational group-based therapies. So these are essentially the crux of all these are that these can they provide education and written material that the patient can view, and that will help them to understand their condition and may help improve their symptoms. So again, if step 2 isn't working, you move on to step 3, and step 3 is high intensity psychological interventions. These can include individual cognitive behavioural therapies or starting drug treatments. So if you are going to start drug treatments, first line would be an SSRI. And if an SSRI can't be used, then you can use a serotonin noradrenaline reuptake inhibitor, such as venlafaxine or duloxetine. And if that doesn't work, then you can use pregabalin. So if step 3 doesn't work, then you can move on to step 4, which is referring the patient to a specialist. But it's important to know. So step 1 is just education and active monitoring. Step 2 is your low intensity psychological interventions, your individual self-help. Step 3 is where you can start drug treatments, and step 4 is refer to specialists in secondary care. So we'll now move on to somatoform and fictitious disorders. So somatization disorders, so these are where the patient experiences multiple physical symptoms, and these cannot be explained by the physical illness, and it can lead to distress, anxiety, and the patients will have frequent appointments with doctors. And the key is that patients, even though these investigations and appointments, the doctors provide reassurance, or the investigations come back normal, and the doctors provide reassurance, the patients refuse to accept that reassurance from doctors. And hypochondriacal disorders, so these are where patients may experience some normal bodily sensations, but for them, they feel that they have a serious medical condition, for example, cancer, and again, they'll go to their doctor for a consultation, for investigation. Those investigations will be normal, and the doctor will reassure them that they don't have a serious physical condition, but again, they refuse to accept that. So somatoform autonomic dysfunction is where you have the patient has symptoms related to the autonomic nervous system, and they'll have symptoms such as palpitations, tremor, sweating, dry mouth, flushing, and hyperventilation. And patients attribute symptoms to a specific symptom, so they may emphasize that they have, that they suffer particularly from shortness of breath or hyperventilation, or that they get, palpitations or sweating more often. But again, it's very important to know these are symptoms related to the autonomic nervous system. So persistent somatoform disorder, it's where you have severe pain which lasts for at least 6 months and cannot be explained by a physical illness. So the pain can occur due to a psychosocial stressor or emotional difficulties. So a patient might have had a bereavement, or they may have had a stressful event in their life, a divorce, and that may translate into physical symptoms. So, and that is a persistent somatoform disorder, and pain is a primary feature. So, just going back to that, I think it's not known exactly why patients have these somatoform disorders, but they may be related to, they could be related to past events such as sexual abuse, or they could be related to the fact that the patient wants to adopt a sick role, or they get benefit from a sick role. So there are sort of certain associations or theories around it, but it's not known exactly why patients have these somatoform disorders. So finally, we have fictitious disorder, malingering. So in both cases, in fictitious disorder and malingering, what you have is where symptoms are intentionally produced. So, i.e., symptoms are faked, but the key to differentiate between the two is what is the motivation in each case. So for fictitious disorders, the patients adopt the sick role in order to receive medical care, usually. And it gives them some internal emotional fulfillment, and we call that primary gain. So they do it for their own emotional and internal well-being. Whereas malingering, the symptoms are intentionally produced for secondary gain. So you produce the symptoms, or you fake the symptoms because you want to get some sort of compensation or some government benefit, or you want to be excused from criminal prosecution. So there is a secondary gain to that. But that's the end of the talk. I've tried to give you the main important points in this discussion, and I would say it's really important that everything that's on the slides and that we've discussed that you should know. But thank you very much.